First of all, I want to send you greetings from New Orleans, which will be the site of the AUA in 2022. So, from the AUA speakers, I want to say hello to our fellow urologists with CMU, the Mexican Congress of Urology, and as the president-elect of the AUA, we are hoping to see you all in person in Las Vegas in September of 2021. We will today be talking about the strategies of managing bilateral renal tumors. This is something that is in 1 to 5% of all cases of renal cell carcinoma. They happen to be bilateral, and they are frequently found in those who have hereditary renal cell carcinomas. In the US, we diagnose over 50,000 cases a year, and this incidence is rising. And the 3% increase per year for the Caucasian and 4% a year increase in incidence for African Americans. So this is something we have to keep in mind when we look at renal cell carcinoma. You are very familiar with the familial RCC. The von Hippel-Lindau's is a familial form with all its findings. And RCC develops in about 50% of patients who have VHL. Don't forget about the autosomal dominant mode of transmission of these. And of course, the AUA guidelines do state that if they are 45 years or younger at diagnosis, then we highly recommend genetic testing for the variants of RCC. Very important. As we know, there is significant angiogenesis because of the vascularity of these cancers. And some of the treatment modalities for immunotherapy, chemotherapy is based on this principle. As you know, most of these are conventional RCC, but 10 to 15% are papillary, which could be multifocal, and so on and so forth. The conventional classification of staging is listed below. How do these patients present? About half of these, and increasing, are detected incidentally because of increased imaging. So when these patients go to the emergency room or they complain of abdominal discomfort, the imaging, whether it is a CT scan or an MRI, diagnoses renal cell carcinoma, and up to 5% of the hereditary ones will be bilateral. So those are the ones that are important to take care of. The triad of gross hematuria, mass is much rarer these days. The preferred imaging modality is number one, to diagnose it if it is localized to the kidney, whether it goes into the renal vein as a tumor thrombus, or if the tumor thrombus goes into the vena cava. So you can use CT scan with and without contrast. We can use the MRI. Don't forget to look for the chest. In select cases, you may want to check the imaging of the brain and also the liver enzyme. So these are some of the things that we recommend in these patients. Management, as you are all aware, has changed significantly over the past decade, especially with the advent of laparoscopy in the 1990s, and then, of course, laparoscopy and the robotics as they came about in the past 19 years in the US. So these emerging surgical techniques, along with the chemotherapy and the immunotherapy, has really changed the management of renal cell carcinoma. One of the big principles that we have found is that nephron-sparing surgery is recommended if at all possible. Even in patients who have one-sided tumors, especially if they're younger, then do the nephron sparing if at all possible. If you are not facile with laparoscopic or robotic, then you can do the open, but make sure that the right surgery is done in your hands. Why is nephron sparing important? Number one, the population is aging. There is an increase in obesity, diabetes, metabolic syndrome, hypertension, and the patients who have one kidney removed, then the solitary kidneys may not be enough to carry them through. So nephron sparing surgery is all the more important. What we do with nephron sparing surgery is usually, if it is a big tumor on one side, you may have to do a laparoscopic or robotic nephrectomy. The open and the robotic surgical interventions are indeed recommended even when you have vena cava thrombus invasion, which is now being done in many centers. So as you can see, here is a robotic technique where we can utilize the robotics principles even in training institutions like ours, where we can isolate these tumors, isolate the renal artery, utilizing the bedside surgeon as the assistant, so that we can then free up the artery and then use the surgical staplers to transect the renal artery. We need to make sure that we have all the required instrumentations to make this safe. As you can see, the renal vein is usually right there, but we need to do a little more dissection to isolate the artery. The imaging, and especially now with the three-dimensional reconstruction, can easily help you identify the exact location of the artery for a nephrectomy. So this is what is done for a nephrectomy when you have a big tumor on one side prior to working on the other side, if that is your treatment option. Certainly, partial nephrectomy has undergone a significant amount of revolution in how it is managed, because we now also have the intravascular, intraoperative ultrasound, which we can drop into the abdomen and then sweep the kidney using the Tile Pro software on the robot, so that we can get adequate margins, and then you can preserve the kidney. So when you have bilateral kidney tumors, this is what we suggest as a possible algorithm so that the patient's nephrons are spared as much as possible. First of all, there should be accurate diagnosis. We need to know what is the renal functional status. You may have a big tumor, but you may have significant normal parenchyma, so that the functional status is important. There should be no metastasis. So as we said earlier, the chest X-ray, the CT, MRI, and in select cases, the MRI of the skull and the brain is also recommended. So the treatment strategy is to minimize the morbidity, minimize the need for hemodialysis, and in some cases, you can use the preoperative TKIs or the immunotherapies as are needed. So what is one of the suggested treatments? So when you got bilateral tumors on both sides, the first kidney is treated almost as a deferred treatment of that kidney, so that the other kidney is in place and will continue to function while the other kidney is recovering from surgery. Very important. Treat one side, and the other side will continue functioning until you take care of the other side as well. This will minimize the need for dialysis and will help the other kidney recover. So we then, whether you do laparoscopic, open, or robotic, You wait 6 weeks before the other side is treated. In certain cases, pre-treating these tumors can also shrink the tumor so that the bulk of the tumor is much less. Don't forget to get the consent from the patient that we may need temporary dialysis. And of course, the consent is also taken that there's a possibility that both kidneys may ultimately have to be removed. So here's a case where you got a large tumor on the left side, and as you move forward, you can see the tumor also on the right side. So your big tumor here, and this one over here. And you can see as you move forward that you still have the tumor on the left side, which is present. So what we did was we proceeded to go ahead and do a partial nephrectomy on the right side with a robot. We still have functioning kidney on the other side. So once this has healed up in about 6 weeks, then we did a nephrectomy, a radical nephrectomy on the left side. Patient did very well. His post-op creatinine was 1.8. We do suggest re-imaging and renal scan for functional status between the two treatment schedules. We can also use ICG, which is not very expensive, to find the location of the tumor and also the location of the vasculature as needed. So this is something that you can also keep in mind. So how about this patient who's got a large tumor on the left side, but he has got significant normal kidney. He's also got a tumor on the opposite side. So in this case, what we did was a left partial nephrectomy, and then we proceeded to do a right radical nephrectomy. Now, somebody might say that you should do the bigger tumor first. That is also a possibility, but you want to make sure that the good kidney that is residual and which will sustain the patient will be sustainable. That's why this algorithm is recommended so that to preserve as much of the kidney as possible. So here's another one with a right robotic partial. And then because this tumor is huge, we then proceeded to do the left laparoscopic radical, because the normal kidney here was able to sustain his serum creatinine. When you have a solitary kidney, it all depends on how your techniques are. You know, these are the ones that we recommend absolute caution, minimize the so-called clamp warm ischemia time. And this may be something you want to do open if you're more comfortable with that. Or if you can tolerate blood loss with transfusions allowed, you may want to do this using the robot as expeditiously as possible. In select cases, patients with solitary kidney can be done open, and then once you have reconstructed it, you can auto-transplant in the pelvis, as we did this with this patient who had a solitary kidney with a big tumor. The role of open surgery is limited to large kidney tumors, tumor thrombus in the inferior vena cava or beyond, or in solitary kidneys. So as we can see from several studies, that nephron sparing is very important in these patients, whether you are giving TKIs or the other immunotherapy protocols in place. These all come together for preserving the patient's nephrons, and therefore between partial nephrectomy and radical nephrectomy in the opposite side, we can now have better evaluation of outcomes as well as minimize warm ischemia time. I want to thank all of you for having me as a presenter for your annual meeting, and I look forward to greater cooperation between the AUA and the Mexican Urological Association. Thank you once again. Gracias.